Travis Johnson, 17, had a tonsillectomy 10 days ago at St. Michael's. Started spitting blood about an hour. Good vitals.
Hey, Travis, I'm Dr. Robbie. How much blood?
A couple mouthfuls.
Can you open up for me?
Post-tonsillectomy hemorrhage is a serious complication following a tonsillectomy. It involves bleeding from the tonsillar bed after surgical removal of the tonsils. So, the primary hemorrhage occurs within 24 hours of surgery, but this isn't the case here. Since it's 10 days, this is secondary hemorrhage, which typically occurs 5 to 10 days post-operation. A post-tonsillectomy hemorrhage is usually caused where there is premature separation of the healing eschar or scab from the tonsillar bed at the site of tonsillectomy. This could be due to infection or inflammation. This is common in children who resume solid food too early or have poor hydration. Typically, there would be spitting of bright red blood like in this case.
Hey, Whitaker, Jesse. Got a post-tonsillectomy hemorrhage.
The first thing to do here would be to suction to clear the airway of any blood. The patient is to be held upright, and an IV access is to be made with IV fluid resuscitation. We got a call for ENT consult because most secondary bleeds need to be taken back to the OR for definitive management, where the electrocautery or suture ligation of bleeding vessel can be done under general anesthesia.
Nebulize TXA quick as you can.
TXA means tranexamic acid. It's an antifibrinolytic, meaning it prevents the breakdown of fibrin clots and hence promotes local clot stability in mucosal tissue like here in the tonsillar bed.
Let's go. Trauma 2. So this can go south pretty quickly. You up for it?
The main concerning issue would be the airway blockage due to the blood, or if the bleeding can't be stopped and is incessant and there is delay in ENT team arrival, it could lead to hypovolemic shock and the patient might collapse with the bleeder still not identified and taken care of.
Oh, I can. Of course you are. Ready? Here we go. 1, 2, 3.
Tranexamic acid is given here in nebulized form using a jet nebulizer to prevent further bleeding from the site by preventing clot disintegration and stabilizing formed clots in the tonsillar bed.
Take long, slow, deep breaths on that. The TXA is going to help your blood clot.
Hey, any medical problems?
No, just a ton of strep. That's why I had the surgery.
He's referring to streptococcal infections in his throat. While the most common cause of tonsillitis is a viral infection, Streptococcus pyogenes is the most common bacterial cause of tonsillitis. If the patient suffers from recurrent tonsillitis, then a tonsillectomy is considered. In fact, the criteria is 7 or more tonsillitis in the past year, or 5 or more each in the preceding 2 years, or 3 or more each in the preceding 3 years. So, a recurrent tonsillitis with strep led to the tonsillectomy here.
You take aspirin, any other medications?
Aspirin is an antiplatelet. It would cause even more bleeding by preventing clots to form and hence has to be stopped if the patient is taking it.
Lungs are clear bilaterally, no stridor.
Stridor is an abnormal high-pitched breath sound, which is produced by turbulent airflow in the upper airways. This could mean a narrow or obstructed airway. Absence of stridor here signifies no upper airway obstruction due to the ongoing bleeding. Yet,
Okay, sure. You feel like throwing up? Any pain in your belly?
No.
Labs?
CBC, BMP, maybe coags?
CBC or complete blood count is particularly important here to check for hemoglobin levels, which could drop due to the bleeding. A BMP or basic metabolic panel measures levels of glucose, calcium, electrolytes like sodium, potassium, chloride, carbon dioxide, along with blood urea, nitrogen, and creatinine. Coagulation profile is definitely needed to check the coagulation status and whether there is normal function of clotting factors in the patient, which is important to achieve hemostasis.
I had a type and screen just in case.
Yeah.
Type and screen means ABO and RH typing of the blood and screen for antibodies against RBCs, just in case transfusion is required.
Good sats are 98%, BP's 115/80.
Okay, good. 4x4 and a ring forceps. Let's take a look.
Head back, open wide for me.
What do you see?
No active bleeding, but there's some white and dark brown stuff where the tonsils used.
So the dark brown stuff that's being referred to in the tonsillar bed is the blood clot that has been formed here. Dried or oxidized blood, meaning blood clots, often appear brownish black. The installation of tranexamic acid has stabilized this clot and not allowed it to further break down and be held there to stop the ongoing bleeding. The white areas he's referring to is the eschar or scab that forms after surgery that we talked about before, which are typically grayish white, the separation of which caused the bleeding in the first place.
Well, that's good. That's a fibrinous clot. That means the TXA is working. Your parents on the way?
They're in Baltimore for a wedding. I didn't want to bother them.
Trust me, they're your parents, and you are in an emergency room, and he's never a bother. Write their numbers down, and I will call them. Call head and neck. Stay with him until they get here, okay?
This is just temporary management here done using tranexamic acid. The definitive management is identifying the bleeding artery and stopping the bleeding once and for all to prevent recurrence, typically done by ENT surgeons in a surgical setting using either electrocautery or suture.
Good. Pen?
Can I get the... No. He had the surgery at St. Michael's, but he's here now. No, he doesn't have a car. His parents are out of town. Okay, well, how am I supposed to send him back to St. Michael's?
Why is the patient suctioning himself? He could dislodge the formed clot with the suction itself and bleed again.
We'll call him an Uber? You can't... That doesn't make... Hey, hello? Hello?
What's wrong?
They said it is not their job to fix another hospital's problem. Don't worry about it, though. I'll talk to my attending.
The temporary measure has failed here. The clot has dislodged and the patient is still bleeding. This should ideally require surgery to identify the bleeding site and fix it as soon as possible.
Oh, shit! I need a little help here!
Okay, come on, open up.
It's a post-tonsillectomy hemorrhage.
Yank out and sponge stick.
He was stable, then it just opened.
Call the blood bank. 2 units. Whole blood. Get a second line.
Head and neck wouldn't come down to see him.
Assholes.
He's tacky to 120. His sats are down to 90%.
Okay, get a high-flow nasal can.
The patient is profusely bleeding and is likely in a state of hypovolemic or more specifically hemorrhagic shock here, along with decreasing saturation due to the bleeding, potentially obstructing the airway and breathing here. This would ideally require intubation, which would be difficult because the airway and vocal cords are difficult to visualize in case of profuse bleeding. Continuous suction would be required, and even then, it's very tough.
100 of ketamine. Set up the glide scope.
Here, they are going to anesthetize the patient with ketamine and intubate him using a glide scope, which is the video laryngoscope to be used for it.
Hold suction. I'm going to try for direct pressure.
We can pack the tonsillar fossa with gauze pieces temporarily to hopefully reduce the bleeding by applying direct pressure there. The gauze piece can be soaked in epinephrine to cause local vasoconstriction of blood vessels as well.
If head and neck still won't come down, call Garcia.
You're good.
What all can be done in the ER for this? Suctioning, gentle pressure with gauze piece soaked in epinephrine, nebulized tranexamic acid, all these are done here. Now only intubation is left, along with the surgical procedure of identifying a bleeder and ligating or cauterizing it, which is ideally to be done in the OR.
Bobby, trauma 2 right now.
Cover the intubation.
Of course.
What happened?
A bleeder opened up.
Ketamine on board to intubate.
Sats holding at 97.
Can you get an airway?
Very difficult to visualize the airway, let alone secure the airway here, all due to the ongoing bleeding that's obstructing everything. If vocal cords can't be seen, intubation can't be done, just like the case of a difficult intubation in episode 2, I guess, where cricothyrotomy was done for it. Let's see what happens here.
Let's lie him down. Keep pressure on the scab. Nothing but blood. Can't see the cords.
Sats 94.
Not sure we have room for the tube with the sponge stick.
If I pull out, there's gonna be even more blood.
Doesn't look like you secured that
We're
airway.
working on it.
Bougie.
Open a crike tray and prep the neck.
I guess another crike in the setting of a difficult intubation again here. In cases where intubation is difficult or fails, cricothyrotomy is done, which means to make a surgical airway by making an incision between the cartilages of the larynx in the cricothyroid membrane to surgically access the airway below the vocal cords, hence bypassing the obstruction or more appropriately, the difficult visualization at the level of vocal cords due to bleeding here.
Hold on. I'm going in blind with the bougie. I might be able to feel the tracheal ring.
Going blind with a bougie means he's using a bougie and directly trying to insert it into the vocal cords without its direct visualization. Here, he would be just relying on the tactile feedback to guide the bougie into the vocal cords and the trachea, which would then guide the endotracheal tube into it.
And I might have a 3-way with Madonna. Move.
Not happening. Pressure.
Make room for the grown-ups.
Okay, Okay, hold on. We can try retrograde intubation.
There's a saying, if you can't see, can't intubate, can't ventilate, then go retrograde. Retrograde intubation is a clever method where you use a needle to access the airway from the neck, pass a wire retrograde, meaning upward through the airway and out of the mouth, and then guide the endotracheal tube over that wire and into the trachea. It's used in difficult intubation cases, or additionally, in cases of limited mouth opening or cervical spine injury. Here, we first identify the cricothyroid membrane, insert a needle to puncture it and enter the trachea, and then advance a guide wire through it upwards from the trachea through the vocal cords and retrieve the wire from the mouth, then pass an endotracheal tube over the wire and into the trachea, then remove the wire and confirm tube placement.
A what?
There's no obstruction. We just can't see what we're doing.
He has got a point though. A cricothyrotomy is done if the airway is physically obstructed due to swelling or edema, as in the case of trauma in episode 2. But if there's just active bleeding and no clots, it isn't a physical obstruction. It's rather a difficult visualization that can be physically bypassed, as a guide wire is easily able to pass through it, which can then guide an endotracheal tube.
So we take a needle and we put it in the cricothyroid. We run the guide wire up and out the mouth, and we slide the ET tube up over the wire.
Never seen one before.
So that's 90.
No time to play MacGyver with this kid. Time to crank.
Did it quick.
A case of retrograde intubation is indeed very rare and isn't really performed that commonly at all. It's more of a plan C, and yes, a cricothyrotomy, which is plan B, is done instead of this if intubation or plan A is difficult.
You got one shot and then I cut.
Even though this process of retrograde intubation suits the patient's airway condition here, the procedure is only ideal in such cases where airway patency is still maintained. If there is no clarity as to if the airway is not visible but patent, or actually obstructed, we can't gamble on a retrograde intubation expecting a somehow patent but not visible airway. Hence a cric is usually the go-to procedure or plan B. They are stopping the bleeding temporarily, with the direct pressure applied with gauze over the tonsillar bed, while on the other hand, a needle is being used to puncture the cricothyroid membrane between the cricoid and thyroid cartilage of the larynx.
Okay, I'm in.
When the needle successfully punctures the membrane and enters the trachea, there will be a sudden loss of resistance, and air from the trachea will be drawn into the syringe, just like as shown in the scene. This is unbelievable accuracy shown here.
Guide wire. Let me know when you start to feel it up top.
Nothing yet. More suction.
I'm trying.
Still can't find it.
Oh, keep feeling in there. It's gotta be there somewhere.
It's curling up.
So that's down to 89.
Guys, this is not working.
Just give me a second.
The job here is to somehow pass this guide wire through the vocal cords and out of the vocal cords into the mouth. And it's a tough one for sure since the time is ticking. We must note here that if the guide wire irritates the vocal cords enough instead of just passing through it, there could be reflex laryngospasm and the glottis can be closed altogether as well, especially if the patient isn't sedated enough.
Until you rest?
She's talking about the respiratory or cardiac arrest that could ensue due to the ongoing hypoxia damaging the brainstem controlling the cardiorespiratory centers.
God, I'm gonna lose another patient.
Stop, Whitaker. He's got this.
So that's down to 87.
Okay, I'm gonna redirect the wire.
So that's still dropping. 86.
You got this.
So that's 84. We need to bag him.
Still not seeing it.
Suctioning like crazy.
Okay, we're done playing doctor. Lose the wire. I'm cranking this kid.
All right, we tried. I'm sorry.
No, wait. I've got it.
Finally, the guide wire is out of the mouth, which means there is a clear-cut pathway now to put the endotracheal tube inside.
You still don't have an airway.
Keep the laryngoscope in place so the tube passes easily. Pass the T tube over the wire. Come on. Hang on to that wire and do not let go of that wire. Okay. Okay, I'm gonna give you a little slack so you can get past the cords. Yeah, I feel you at the trachea.
25 centimeters at the lips.
That ought to do it. Pull the wire, bag him.
Balloons up.
Yellow on CO2. That's good.
The end-tidal carbon dioxide indicator is a colorimetric device that detects exhaled carbon dioxide to confirm if the endotracheal tube is in the trachea or esophagus. Yellow means exhaled carbon dioxide is adequate, meaning the tube is in the trachea.
Good.
That is very good. Good breath sounds bilaterally.
So that's coming up. 90, 92.
Guess you're gonna have to save that scalpel for another day.
You guys got lucky.
No, we got skills, baby. We got skills. Keep gauze on the clot.
Yeah, copy.
Ordering propofol and fentanyl drips.
The ER team has done what it could, securing the airway and temporarily stopping the bleeding by mere pressure over the tonsillar bed. Now it's the time for ENT to step in and do the honors of identifying the vessel and ligating or cauterizing the bleeding vessel in the OR.
Oh, nice of you to join us, Dr. Flores.
Sorry, got stuck in a nasty radical neck dissection. Still bleeding?
Not with direct pressure.
We got the airway, you get the bleeder.
OR standing by.
So I can cancel the Uber?
Let's get him upstairs.
Fresh sponge stick for you, Whitaker.
You need me to stay with the...
Your patient did a good job. It's only till the anesthesiologist takes over. You got it?
Yeah, I got it.
Get yourself a fresh pair of scrubs on your way back down.
He has to be in this position, holding the gauze in place there until the patient is shifted all the way into the OR until the team there takes over. That could take a long time, or it feels like a long time to remain in one position holding the forceps. Even bagging the ambu bag tires you after a while.
Retrograde intubation, that's an Adamson special. I learned that from the best.
Wow, you're not too shabby yourself, Professor.
Yeah, that got kind of rough in there. You kept your composure, though. Exactly the kind of candidate they want for the ED Medical Education Fellowship.
Oh, there's probably over 50 applicants for that one slot.
Yeah, probably. But I know that they like to go with someone that they know from firsthand experience has the skills to be successful. At least that's what I told them in my letter of recommendation.
Thank you.
Now that's a good attending resident relationship or a mentor-mentee relationship.